Go ahead.
Hi, my name is Dr. Boender and I'm with Dr. Lee-Rodgers. We are fellows in the Reproductive Mental Health Clinic at MUSC, and we are here to talk about new treatments for postpartum depression, Brexanolone and Zuranolone. We have no disclosures. We do want to mention that these are newer medications that are specifically for postpartum depression. And so we will be talking about Brexanolone and Zuranolone specifically. We are not advertising for the Sage or the therapeutic company that makes this, but these are the only two that are currently on the market in this class. So that's what we'll be talking about. Just to give a little bit of background on postpartum depression, the diagnosis for postpartum depression is from the DSM, and so that's what we use. It's the same criteria for depression outside of pregnancy as well. The DSM does have specific criteria or areas that you can put in that is for depression during pregnancy and postpartum. Other psychiatric disorders don't have that specific label that goes with pregnancy, but we often do see bipolar disorder and anxiety and other things getting worse during the pregnancy and postpartum time period as well. But today we're specifically talking about postpartum depression. When we talk about risk factors for perinatal mood and anxieties in general, there are a lot of different risk factors that women have. We won't go through all of them, but you can see and you can look at the slides later that multiple things play a role. So it's important to be mindful that many different things can play into this. Incidence of the perinatal mood and anxiety disorders. When we look at, you can go to the next slide. Incidence for the perinatal mood and anxiety disorders. There was a study by Wisner et al. That followed 10,000 women, and they found that if a mood or anxiety disorder was present during pregnancy or postpartum, 68% of the time it was unipolar depression or major depressive disorder. About 2/3 of those did have comorbid anxiety disorder. So also very important when you're screening patients to not just screen for depression, but also screen for anxiety. 22.6% of women in this study actually had bipolar disorder. So as a provider, it's very important to not just be screening for depression, but to be screening for bipolar disorder as well. ACOG recently had some new resources that they put out about screening in pregnancy and postpartum. So that's a good reference to go back and look at as far as screening for bipolar disorder. But today, when we talk about Brexanolone, Zuranolone, it is for depression and not bipolar. So you do need to screen for that. 19% of women who had a perinatal mood anxiety disorder did endorse thoughts of self-harm. So also very important to pay attention to that as well. You can go to the next slide. As far as screening, because it is so prevalent, it is important to screen. Different major bodies have different recommendations for how often. The American Academy of Pediatrics recommends screening at well-child checks at 1, 2, 4, and 6 months visit. ACOG recommends screening at the initial prenatal visit, again later in pregnancy, and then at postpartum visits as well. AAFP has recommendation for screening at that postpartum visit or well-child check. Postpartum Support International, which is an organization that focuses on the perinatal mood and anxiety disorders, recommends screening at various different times during pregnancy and postpartum. So everybody kind of has different recommendations for how often, but it's important to screen. And there's lots of different ways you can screen or that's been validated throughout pregnancy. The EDPS, PHQ-9 are both tools that can screen for depression. The mood disorder questionnaire is a screening tool for bipolar disorder. So there's different tools that you can use.
Here we go, next slide. So as she said, you can use different tools like the PHQ-9 or the EDPS, but one that is very often used is the EDPS. So I thought I would just highlight it for a moment, just as kind of like a basic outline. It is 10 questions, and it's 10 questions specific to the past 7 days before the encounter. Of each question and each symptom, there's a score of 1 to 3 that they use to gauge severity, and the maximum score is 30. One thing that I think is worth knowing with the EDPS is that there is no like sure line or sure score of positive or negative. And there have been studies to kind of try to figure that out. So all of the studies that are reviewed for that in general, the score of 11 is kind of where we see like a maximum specificity and sensitivity at the same time. So clinically, I think that's probably the best score to use as far as determining positive or negative. You can go to the next slide. And this is just what you'd see in clinic and what the patient would see if you were to give them the screening measure with the 10 questions and then each being scored on severity of 1 through 3. Next slide. When we talk about depression in pregnancy, I think it's important to note that it's more common than we often assume, and that up to 15% of women are actually affected. Excuse me. More importantly, I think we should have a really good understanding of the effects if we don't treat the depression. So if we don't receive any treatment and a woman experiences depression throughout her pregnancy, there's lasting negative impact on both her and the baby. And I don't need to read all of these, but in general, it makes it harder for moms to participate in prenatal care adequately. There are higher rates of substance use and then multiple complications, including preeclampsia, preterm labor, and C-section. It's also a very, very high risk factor for later development of postpartum depression. And then if we look at the baby itself, they've done studies that show that while inside mom, they're actually more active and they display greater stress behavior later after delivery. So overall increased cortisol, increased norepinephrine, and increased stress markers. They also know that there's some data that shows that there's lasting epigenetic changes, specifically when it comes to methylation of collagen formulation genes. We don't know the clinical manifestation of that yet, but we do know that it will affect the baby on an epigenetic level, and that after delivery they will display greater lability in blood pressure, heart rate, etc. And I think we already mentioned preterm delivery and then the frequency of NICU admission. If we then transition to postpartum depression and we don't treat that, again, there's higher rates of substance use and limited participation in care. There's also really significant impact on bonding between the mother and the baby that will affect both her and the child later in life. And definitely high rates of maternal suicide, which we'll talk about again on the next slide. As far as effects in the infant and the child, we know that if moms have depression during pregnancy and into the postpartum period, that in general, babies have a harder time developing. So there's poorer cognitive functioning, they have more behavioral issues. As an infant, their sleep patterns are not as stable as babies whose mothers weren't depressed, and they have higher rates of illness by 3 months, specifically diarrheal illness, and the reasoning for that is not yet understood. Next slide. When we look at suicide risk in the postpartum period, there's a lot of attention given to screening at like the 6-week visit or at the 2-month well child, which is great, but that's actually not the highest risk period in the postpartum period. That's actually from 6 to 9 months. So I just wanted to highlight that and just kind of remind everybody to keep screening throughout that first year and to really pay attention after 6 months and that 6 month to a year period, because the risk is higher than it is initially after delivery. Next slide. So now we're going to talk about treatment options. And in general, these are the modalities that are available to us. We're not going to really talk about therapy or SSRIs today. We'll focus more on Zuranolone and Zuranolone. Next slide. Next slide. When we talk about Zuranolone and Zuranolone, I think it's important to understand the underlying mechanism. So what we do know is that the breakdown product of progesterone is something called allopregnanolone. And allopregnanolone is a positive modulator at the GABA-A receptor, so overall increases GABA transmission at baseline. When using Zulresso, we don't have to adjust for renal or hepatic adjustment or failure. And you do want to exercise caution in CNS depressants because there is risk for some combined effect in oversedation. During breastfeeding, we usually just have conversations with the patient themselves. It's kind of on a clinical level and an individual basis, because we don't have adequate data to say whether it's a hard or very clear yes or no. What we do know is that there is a risk of sedation. So if the patient is to breastfeed, we usually caution and just explain that there is a risk there and that they probably want someone else with them should they choose to continue breastfeeding while receiving the infusion. Most patients, when I had that discussion, had decided not to breastfeed for that period and to pump ahead of time, to allow them to rest and to really take that time in the hospital. But it really is ultimately up to your conversation with the patient. And then of note, there is a risk of fetal harm, so I do recommend prevention of pregnancy during that time period. Next slide. When it comes to administering Zuranolone itself, it does have to be done at what they call a REMS certified healthcare facility. It is a 60-hour IV infusion. So during that time, the patient is within the hospital to allow for monitoring. That occurs every 2 hours, and it's really via pulse ox and monitoring for sedation. But therefore, during that time, the patient can't be the primary care provider. And I think that's really important to explain to them when you're discussing what treatment would actually look like. I think it's also important to talk about medication price because it's very expensive. So nearly $40,000 without any insurance coverage. Having said that, the company itself does provide different programs to assist with payment. That's completely up to the patient and the conversations they have with their insurance company. So I don't have a ton to say about that because it's so variable depending on what insurance coverage they have. I do think as clinicians, it's important to know that the prior auth process for the Zuranolone is very long, and can take like weeks. So while you're filling out all the paperwork to get it covered, we do treatment in the meantime. But I think it's important to know that it's not something that you can recommend and necessarily get the patient in like the next week or even the week after to start. It usually takes some planning up front. Next slide. When we look at the data regarding the efficacy of Zuranolone, there was a significant placebo response, but there was also a significant reduction in HAM-D scores of up to 5.5 points. One thing that I really like about the infusion is that people actually see improvement in as early as 2.5 days, and that outcomes 30 days later are actually very positive. And I think I mentioned it earlier, but there is a risk for excessive sedation and sudden loss of consciousness. They're not often, but they do occur. And when loss of consciousness did occur in the studies, people woke up between like 15 and 60 minutes later with continued monitoring.
I'm going to talk a little bit about Zuranolone. This is the newest med that just came out. It was FDA approved on August 4th of this last year, and it did take a little bit of time to go through figuring out what the medication costs and insurance coverage will be. So really it's just been within the last several weeks that we started using it. The medication cost without insurance is $15,900, but we've been finding that a lot of insurance companies do cover it. And again, they have assistance programs through the company that makes it. So if there is an issue with coverage or cost, definitely worth reaching out to the company as well. The mechanism of action, we don't know exactly how it works, but it's the same where it acts on the GABA A, and because that is where Brexanolone acts on, we're thinking that that's the connection. Eligibility, women need to meet the criteria for depression, and specifically the studies showed it was onset of depression within the 3rd trimester or the first 4 weeks postpartum. And so this is not something that it was studied where a woman has had long-standing depression that was not well controlled and they're at their baseline that has not been controlled for a long time, but now are postpartum. This would be more either new depression during that 3rd trimester or the 4 weeks postpartum, or if they had been stable and it worsened during that time. As far as dosing, the medication comes in 20 milligrams, 25 milligrams, and 30 milligram tablets. The standard dose is 50 milligrams daily, which would be 25 milligrams you take they take 2 of them at a time, and you do that for 14 days. This medication is meant to be for 14 days. You don't use it repetitively. There hasn't been any studies to repeating the dose later. It is a one-time treatment. If while taking the medication, the mom starts noticing CNS depressant effects or they're feeling sedated, then the dose should be decreased to 40 milligrams daily, which would be 2 of the 20 milligram tablets. You do dose the 30 milligram tablets if they have severe hepatic disease. So if their child PUC score shows severe, or if their child puke score is a C, or if they have moderate to severe renal impairment where their GFR is less than 60. Those are both instances where you'd only use 30. You also do dose adjustments if they're on a strong CYP3A4 inhibitor. You avoid use with CYP3A4 inducers, and then avoid use with CNS depressants if possible, and if not possible, then consider dose reductions. So the CYP3A4 inhibitors, if you use them concurrently, it might increase the risk for adverse reactions or that sedation, and so the recommendation is to only use 30 milligrams daily, and there's some examples listed of some of the medications that would be included in that category. For the CYP3A4 inducers, can we go to the next slide, please? With the interaction between, it can decrease the effect of the Zuranolone, and so they recommend avoiding use together. And that'd be phenobarbital, phenytoin, rifampicin, St. Johnson's Wort's glucocorticoids. And then if the patient has CNS depressants, so benzodiazepines, opioids, tricyclics, you can go to the next slide, please. So if they're using CNS depressants, that can increase the impairment or CNS depression that patients get from the medication. And so the recommendation is to avoid use. Make sure as well if they're using alcohol that they don't use that they don't use while they're receiving treatment. If you're unable to avoid for some reason, then consider dose reduction to help limit that effect. For patient instructions, patients should be instructed to take this medication in the evening with a fatty meal for 14 days. And they have it set up how many calories and the percentage of fat that's recommended for this. If a patient misses a dose, they should not take 2 doses in the same day. You take the extra dose, then that next day when you find out that you've missed a dose, but complete 14 days total. So you just keep going, but don't double up. If they are on an SSRI or SNRI, continue that if indicated. You need to instruct them to use contraception during the full treatment and for a week following. And then also, and this is important, there is activity restrictions for 12 hours after each dose. Go to the next slide. And so warnings and precautions, there is a black box warning, and this is listed in the box below. So it can cause driving impairment due to central nervous system depressant effects. And so you need to advise patients not to drive or engage in other potentially hazardous activities until 12 hours after administration. And also explain to patients that they may not be able to assess their own competence or their degree of impairment. So it's just really important after each dose, they wait 12 hours for driving or other potentially hazardous activities. And so the warnings it can impair ability for hazardous activities. It can cause CNS depression like somnolence or confusion. It can cause suicidal thoughts, behaviors, just like the other antidepressants are listed with that as well. And then potential for embryo-fetal toxicity as well, which is why contraception is important. And there is a registry if patients find out that they were pregnant or became pregnant during use. As far as side effects, the side effects that have an incidence of over 5%, drowsiness, 36% of patients had reported drowsiness, also dizziness, diarrhea, fatigue, common cold symptoms, urinary tract infections were the most common side effects. Breastfeeding, we don't have much data on breastfeeding in the initial trials. They did not do that. They have done a few very small trials since then, show the relative infant dosing is low, less than it is for the SSRIs that we frequently use. But because we don't have a great amount of data, it's shared decision making with the patient, discussing the benefits of breastfeeding versus the potential risk with the lack of data. So the options to discuss with the patient is continue breastfeeding, breastfeeding cessation, or pump and dump during and for that week following. And so that's just the conversation. Again, the relative infant dose is thought to be very low, but we just don't have the data to say there isn't risk involved. And then how to prescribe. There are only 3 specialty pharmacies that at this point you can get this filled through. So if you're wanting to prescribe this for a patient, you would send the prescription to either a Credo, CVS, or Walmart specialty pharmacy, which are the 3 pharmacies they have that are filling right now. The pharmacy will initiate the approval process with insurance. If there's other paperwork, they would send it to you. And then they would also discuss the patient affordability program if necessary. It is important to tell your patient, if you're going to use this, that they must answer the call from their pharmacy, because once the script is in, the pharmacy needs to talk with them. So if they don't answer the call, they're not going to be able to get that filled. And then after it's been approved, it will be sent to the patient. If the patient does have increased sedation and the dose needs to be changed, you would call that in, and then they would send the lower dose which would be free of charge based upon my conversations with Sage Therapeutics, that they would send that in for patients to complete their therapy. And then you can go back up. This is our case study.
Okay, everyone, 1 second.